74894.
Hey, can I get a comm check? Can y'all hear me out there? Thanks much. And can you see the slideshow on your screen now? All right, rock and roll. We'll get started right at noon. Thanks. All right, we'll get started in about 3 minutes.
This meeting is being recorded.
All right, folks, good afternoon. I've got 12:01, so we're going to go ahead and get started. Uh, Hopefully, everybody's hearing me well out there. Another thumbs up that I'm coming through on the audio. Okay, great. So let's reorient where we left off yesterday. We were still hanging out in the anterior pituitary, right? So we were discussing the adrenocorticotropic hormone or corticotropin, and we mentioned that we have a method by which identifying if we're going to have primary adrenal insufficiency, which is the destruction of all regions of the adrenal cortex, which is the slide that I'm sharing here, versus secondary adrenal insufficiency. Most common cause is that reduced glucocorticoid production, secondary to decreased ACTH levels from sudden cessation of exogenous steroid use, which we got to this point yesterday, and now we're going to dig a little deeper into the agent, the casinotropin or quartericin synthetic human ACTH. And we're going to talk about how we utilize that, much like the thyroid hormone that we talked about yesterday, for identifying when folks undergo an ablation or surgery if they still have thyroid function. It's going to be such in the tested in the same way, but now with a with casinotropin or cortisone. There's a little bit of lag with the transfer of the slides here. Okay, so in primary adrenal insufficiency, like we discussed, the destruction, cortisol is going to remain low after we give the casinotropin injection because the gland itself is destroyed. So the gland cannot respond to ACTH stimulation. So no matter what we do, no matter how strong the stimulus, it's not going to, the adrenal cortex is not going to respond and make cortisol. However, in secondary adrenal insufficiency, the cortisol can remain low or vary. The gland is still there, but there's some kind of understimulation or atrophy of the adrenal cortex. So the adrenal cortex is chronically being understimulated or atrophied because of a lack of endogenous ACTH. So the response can be somewhat blunted or delayed. And then in normal, we expect when we give the casinotropin that the cortisol is going to rise. It's going to rise up after we give the ACTH stimulus. And that's just showing on the axis here. So broken in primary, that's your middle shortcut. That's what you need to think about. So it never responds, regardless of how much stimulation it gets. And that's the big differentiator from secondary disease. So what do we have if we inject the the carcinotropin in primary? It's going to remain low because it can't respond. The cortisol remains low. And then in secondary, it's going to remain low or vary, as I mentioned. Our normal patient, what's going to happen? Cortisol is going to increase. So make sure you understand this HPA axis and the response, depending on what's going on at the adrenal cortex, the response of cortisol the adrenal cortex can produce based on the test with the carcinotropin injection. How it responds with remaining low in primary, secondary adrenal cortex issues, it remains low or it varies. And then in normal patients with normal function adrenal cortex, cortisol is going to increase due to that stimulation down the HPA axis. So we just discussed it, just to review what we just discussed, right? Just make sure you understand what's happening with the the HPA axis with response to carcinotropin with release of cortisol. Is it going to increase, remain low, or vary or remain low? We just went over it, so you should all know the answer to that now. If not, go back to the last slide. So now we're shifting gears. We're still in the anterior pituitary, but now we're talking FSH and LH. Follicle stimulating hormone, FSH, or luteinizing hormone, LH. So now we're back in that hormone replacement fertility therapy. So the clinical uses there, ovulation induction using FSH and or LH in infertile women with gonadotropin deficiency. And also two of our agents can be used with male infertility for spermatogenesis induction using FSH. And so be aware when you look down at the slide on the agents that the philotropin alpha, philotropin beta, the gonal F, and the follistim, that's both for male spermatogenesis induction and also for the females for ovulation induction, the two main uses. But when we talk about the urophilotropin or UFSH, Ravelli, or the lutropin alpha, Leveris, those are only for ovulation induction. So make sure that you know which ones are used for both male infertility and female ovulation induction, and which ones can only be used in ovulation induction, the last two. Usually you're going to see this being utilized in fertility clinics, right? You're unlikely to be prescribing follicle stimulating hormone, luteinizing hormone, any of those agents. However, you are going to have patients that are on them when you're doing your med reconciliation. So you need to be aware of them, and the board expects you to understand them. Not, a deep dive into it, but do understand what they're used for and understand the mechanism of action. So now we're going to discuss prolactin, which we talked about yesterday. This was the unique hormone, right, from the anterior pituitary. Important note is that prolactin is structurally similar to growth hormone, and it's the principal lactation hormone. Milk production is going to require the prolactin plus permissive levels of some other hormones. They're listed there for you: estrogen, progestin, corticosteroids, and insulin. But we talked about the we talked about the physiological quirk here with prolactin in earlier slides. It's unique among these anterior pituitary hormones because it's under tonic inhibitory control And we mentioned that was by dopamine, also known as prolactin inhibitory hormone from the hypothalamus. So it's not under stimulatory control like the rest of the hormones from the anterior pituitary. That's why everything that blocks the dopamine raises the prolactin, whether that be other drugs or some compression at the stalk between the hypothalamus and pituitary. So the clinical presentation you're going to see with hyperprolactinemia in women is going to be amenorrhea, anovulation, infertility, hirsutism, and then in men, it's going to be erectile dysfunction, decreased libido, gynecomastia can happen, reduced muscle mass. So both sexes can develop headache and visual disturbances if you have a macroadenoma. And you're going to talk about this in neuro, and the juniors have probably already talked about it in endocrine as well. But if you have that macroadenoma that's compressing the optic chiasm, that's when you're going to get classical bitoral hymenopsia or bitemporal. I'm not going to ask you about it. Just know that's a classic sign when you have that macroadenoma compressing the optic chiasm. So for a prolactinoma, we want to, before we jump right on it being a prolactinoma, always ask about meds, right? Because we've talked about in other courses and in our course that certain medications that are dopamine antagonists, such as antipsychotics, we've talked about metoclopramide, so Reglan, some of the antidepressants, so drug-induced causes are wide for a wide cause of hyperprolactinemia. It's going to mimic a tumor because obviously it's going to antagonize your primary stimulant of inhibition, right? It's going to antagonize dopamine, those drug classes. Like I said, we got a little lag on the slide transfer. Okay, so for hyperprolactinemia, we said we're going to use the dopamine agonist, right? Because dopamine or D2 is inhibitory. It's the natural brake on prolactin. So dopamine agonists are the first line when we talk pharmacotherapy for suppressing prolactin. They're going to decrease prolactin release. They can shrink a prolactin secreting pituitary tumor, lower the circulating prolactin, and restore ovulation. For microadenomas, I think it's on your slide there, it can restore ovulation for about 70% of women with a microadenoma. And then for larger tumors, macroadenoma is about 30%, just so you're aware. It's interesting to note that prolactin secreting adenomas typically are still sensitive to dopamine's normal inhibition or inhibitory signal for prolactin release. So that's why these dopamine agonists work so well, even against tumor tissue, if it's an adenoma causing the prolactinemia. Unlike other functioning adenomas that will escape that normal regulatory control. So dopamine agonists are also used in acromegaly. So normally we're thinking growth hormone for acromegaly, but the dopamine agonists are also used sometimes as an adjunct, right? Because GH release is co-stimulated in some of our acromegaly patients. So we're going to utilize it sometimes with the dopamine agonist, but it's going to be much higher doses than we're going to be utilizing for hyperprolactinemia. And then our players are the dopamine agonists or agonists that we're going to talk about on the next slides, I think, bromocriptine and cobalamin. So we can use them in acromegaly because they suppress the growth hormone secretion in some patients. So know that we're talking two different suppression mechanisms when we look at growth hormone. The one that we talked yesterday, and now we're seeing a secondary use of dopamine agonists. So normally dopamine in the hypothalamus is going to inhibit GH release by acting on the D2 receptors. But in acromegaly, because the GH secreting adenoma often has reduced receptor expression from dopamine, we do get in GH sometimes altered dopaminic regulation. So that dopamine's inhibitory effect on GH can be affected, and that's why we can use them um, in acromegaly as well. So we talked about the clinical pearls here, right? 70% of ovulation is restored for females with microadenomas and about 30% in macroadenomas when we're looking at utilizing the dopamine agonists. So when we talk the differences, right, between the anterior pituitary hormones, contrast a hyperprolactinemia situation where the first line of a prolactinoma, regardless if it's micro or macro, we're going to be utilizing our dopamine or D2 agonist pharmacotherapy. Whereas when we talked about acromegaly yesterday, first line is going to be that surgery. So make sure you can keep those two apart. The different first line treatment. So for the hyperprolactinemia, two oral agents you need to be aware of, and it's large and exclamated on there on the slide because this is really the first time we've talked about our agents for treating dysfunction of the HP axis with oral meds. So bromocriptine or Parladel is daily, and the cabargine or Distanex, that's twice weekly dosing. So carbagylene obviously has a longer half-life. That's why you can use the twice weekly dosing. So it's generally preferred, and you need to make that distinction that carbagylene is generally preferred, that and the adverse effects. Right? Across both medications, adverse effects are going to be nausea, headache, diarrhea, abdominal pain. But not only does the carbagylene have that longer half-life, but the nausea is much less with carbagylene versus the Parladel versus the bromocriptine. So make sure you're making that distinction between the two different D2 agonists. And then the rest of the adverse effects are listed there for you. Interestingly, kind of the same effects we see when we start using dopamine agonists for our Parkinson's patients. And you'll talk that in neuro if you haven't already. So the key take home here is carbagylene of the two dopamine agonists generally preferred over the bromocriptine because of efficacy and also better tolerance, right? Less frequent dosing and better profile for the nausea adverse effect. So answer here, right? Dopamine agonists work by doing which of the following? They're going to decrease, right? They're going to decrease prolactin secretion because of that unique inhibitory effect of dopamine on prolactin. So here is just a good table for you to review, just showing which anterior pituitary hormones with which hypothalamic stimulator there on the right, and then the primary function of that hormone, and then the primary inhibitor on the far right. So if you don't remember normal for the HP axis, this is where you need to start so that you understand normal, so that you understand when we're using our agents somewhere in the HP axis, how they're being utilized either as agonists or antagonists to either decrease or increase the amount of the normal hormone that should be being released by the anterior pituitary. So a good study guide if you need that refresher. Now we're moving to posterior pituitary. Good news here, only two hormones to master. They can be a bit complicated, but many less hormones than the anterior pituitary. So ADH or AVP and oxytocin are the two we're going to talk about, plus their pharmacological mimics, vasopressin, desmopressin, and then for oxytocin and pitocin. Remember, for the posterior pituitary, that that the posterior pituitary stores and release hormones, doesn't make any, only stores and release. In contrast to the anterior pituitary, the posterior pituitary hormones are coming from the hypothalamus, being stored in the posterior pituitary. So we're going to start off with antidiuretic hormone, ADH, also known as AKA arginine vasopressin or vasopressin or AVP. So you'll see those terms used interchangeably. So just make sure you're aware when you see arginine vasopressin or vasopressin or AVP, we're all referring to antidiuretic hormone. So there's an error on the slide, the second bullet, right? Peptide hormone produced by the posterior pituitary. Incorrect. Incorrect. Right? The posterior pituitary does not produce hormones. I'll change that on the slide deck to secreted by the posterior pituitary because ADH is being made up of the hypothalamus. Then their end target, their receptor site, is the collecting duct of the kidneys and also the blood vessels. And we'll talk about those two different mechanisms. So what does it do? In the collecting duct, the ADH is going to increase water reabsorption. Makes sense when you think about antidiuresis. So we're going to increase the water in our system, keeping it back into the blood, and then we're going to have less water going out with excretion of the urine. And then the second site of action down on the blood vessels, vascular smooth muscle, the antidiuretic hormone is going to increase arterial pressure. And we're going to talk briefly about normal physiology so we can understand pathophys and then our agents that we're going to use to correct coming up. Now, remember that from anatomy, right, that osmoreceptors in the hypothalamus are going to detect changes in salt or sodium concentration in your plasma, and that's going to indicate whether we need more or less water conservation in our system, which then we're going to see how antidiuretic hormone acts in those scenarios. So what are the stimuli for ADH release? So what causes antidiuresis? Caused by a release or an increase in antidiuretic hormone secretion. So the reason that the ADH will be released into our system, hypovolemia, hypotension, increased plasma osmolarity, and then also some receptors on the renin-angiotensin system, right? So and the angiotensin 2 is going to increase sympathetic activation. So the take home there is that ADH release is going to be triggered by volume-based, so baroreceptions based on the volume of fluid in our system, and then also the concentration-based receptors, osmoreceptor signals. And osmolarity being the more sensitive trigger normally for ADH release. So a reminder that normal serum sodium there on the slide, 135 to 145 milliequivalents per liter, tightly maintained despite wide variation in fluid intake by our patients. So when the plasma sodium is hypertonic, above 145 milliequivalents per liter, we're going to secrete ADH, driving renal water reabsorption, and then forcing our patient to produce more concentrated urine, which is going to bring the sodium in the patient's system back down. But when the plasma is the opposite, if the sodium is below our normal serum sodium level of 135, i.e. hypotonic, so ADH is then going to be suppressed because the negative feedback is going to allow free water to be excreted to correct this dilution of our patient system. So really, if you understand this slide, you're going to understand the whole physiologic foundation for both the disease processes we're going to talk about with reference to antidiuretic hormone, diabetes insipidus, so too little of an ADH effect, and we can't concentrate urine. We get hypernatremia, and contrast that with the syndrome of inappropriate antidiuretic hormone. In that case, it's going to be too much ADH, so we can't dilute the urine. So we're going to have hyponatremia. We're going to talk about each condition and then which agent we're going to use for the ADH correction based on whether we have too much or too little happening with reference to ADH. So as long as you understand this slide, the disease processes or the pathophys is going to make more sense to you. Keeping in mind those normal serum sodium ranges, right? 135 to 145, pretty tightly regulated. But if you keep those in mind and all the references when we start talking about diabetes insipidus versus SIADH will make more sense to you to be more clear which agents that we're using. So if you understand the feedback loop, you'll be able to predict the ADH directional response given a sodium or value or knowing the patient is hypotonic versus hypertonic or vice versa. So if you can master this slide, then you'll be able to work your way through all of the diabetes insipidus and SIADH questioning. So here we're just talking the overview, right? So the hypothalamus, based on what we just discussed in the last couple of slides with those inputs, angiotensin 2, sympathetic stem, hyperosmolarity, or decreased atrial receptor firing, is going to send the signal out to the posterior pituitary. Posterior pituitary is going to release vasopressin, right? And then there's two receptor sites that we mentioned, the blood vessels. So V1 receptors on the vessels are going to constrict. That's increase in systemic resistance versus the other end organ target for vasopressin V2 at the kidneys. That's going to cause the fluid reabsorption at the kidneys, which in turn is going to increase arterial pressure as well. And then the blowout on the right, the slide is just showing, patient there working out, rollerblading around, sweating, decreasing blood plasma, so hemoconcentration, hypothalamus gets stimulated, and that's going to stimulate the posterior pituitary. And here comes our ADH, and then they're going to act at those two sites, and the picture is showing their action on the kidneys. So let's reabsorb more water in the plasma due to that ADH response. And as I said, increased plasma volume, increased arterial pressure. So just your overview. So vasopressin is our agent, synthetic ADH, with activity at both V1, V2. So we talked about those two sites, what they do at the vessels, and what happens with ADH when it is affecting the kidneys, what the actions are. So vasopressin or pitressin IV medication hits both of the end targets, both receptors, right? Both receptors in the collecting tubules, the V2 receptors, and also a short time action causing vasoconstriction in the V1 alpha receptors, which are there on the slide. So we do sometimes exploit the V1 action in shock states. You'll get that in EM and some other lectures, but that's why vasopressin sometimes is used in shock for that vasoconstriction role, short term vasoconstrictor role at the V1A receptors of the vessels. So the adverse effects kind of follow directly from this dual receptor activity of vasopressin. So water intoxication or hyponatremia from V2 overactivity and vasoconstriction from the V1 alpha activity. So it kind of makes sense that we'd have to be careful with vasopressin because of its V1 activity, in coronary artery disease, or if our patient has some type of cardiac ischemia, that V1 activity, V1 alpha activity can actually be dangerous if we're going to put vasopressin on board with a patient that has already an underlying coronary artery disease or some disease process resulting in cardiac ischemia. So a big concern there, but the good news is we have a more specialized or targeted medication to agent that we're going to talk about, which doesn't have the V1 alpha activity, desmopressin, and we're going to talk about that in the upcoming slides. So historically, because of this dual V1 alpha and the V2 activity, we used it in shock for the V1 alpha activity, and then we used it much more uh, in the past than we do now because of its for its antidiuretic replacement for central DI or diabetes insipidus. But that dual activity is why it's largely replaced by other agents, which we'll talk about coming up in the other slides. Big take home point here is knowing that the vasopressin has that activity at both the receptor sites and that we have a precaution with any patient with coronary artery disease or cardiac ischemia because of the V1 alpha activity, the vasoconstriction. So make sure you keep that straight when you think the adverse effects of vasopressin versus the other ADH agents. So how do we use vasopressin? We talked about it briefly. The first way we're going to use it out of three major utilizations for the vasopressin is central diabetes insipidus. So what central diabetes insipidus is going to be caused by reduced pituitary ADH secretion. So that's going to be central or neurogenic, as opposed to renal unresponse to antidiuretic hormone, which we call nephrogenic diabetes insipidus. Makes sense because central diabetes insipidus is an issue up at the pituitary releasing or secreting ADH, so it's central or neurogenic, versus the renal unresponsiveness to the antidiuretic hormone or ADH. So when it's happening because of an issue at the kidneys, then it's going to be called nephrogenic diabetes insipidus. Both causes will create large volumes of very dilute urine, which means our patient can get dehydrated, they're very thirsty, and we used to use central DI historically, like I said on the last slide, treat it with vasopressin. But now we use an upcoming agent we're going to discuss, desmopressin, right? Because of its more favorable selectivity, not having that V1 alpha activity on the vessels as much as the vasopressin. Secondly, we have another agent now, one of our hormones that we can use to control esophageal varices bleed. We talked briefly about the octreotide and splenic vasoconstriction to reduce portal pressure. So we can use an antidiuretic hormone, vasopressin, the same. It's going to also help with shutting down that splenic blood flow and causing vasoconstriction, reducing portal pressure. So we're going to use it much like we talked about octreotide yesterday in growth hormone. Thirdly, I mentioned it on the last slide, we can use our antidiuretic hormones for the management of vasodilatory shock, septic shock, anaphylaxis, where we need vasopressin's V1 alpha vasoconstriction action to restore vascular tone. I do note, and you've probably had this in cards already for the juniors and sophomores to get it when you get there, but there was a historical use for vasopressin as an option for asystole. So when we start acute coronary syndromes, ALS, we used to have, before 2015, vasopressin was going to treat or be in the algorithm to treat asystole, but now it's just epinephrine. Epinephrine preferred, and this is just FYI, know that the vasopressin is no longer in those guidelines. That's just for you to be aware of. And then another pants note here is that the central diabetes insipidus now primarily recommended be treated with the dasmopressin, not vasopressin, because the uh, the activity difference. And we're going to talk about it in the next couple of slides. So we talked about the vasopressin. So here's desmopressin, still issue with the antidiuretic hormone, desmopressin, also known as DDAVP, but it's basically just a long-acting synthetic vasopressin, vasopressin analog, but it's engineered for its selectivity at the V2 receptors, not very much action at V1 alpha receptors. And note on the slides, the antidiuresis to pressure ratio of desmopressin is 4,000 times that of native vasopressin. So that selectivity for antidiuresis is the entire reason that it's replaced vasopressin for non-pressor indications. So antidiuretic benefit, far less vasoconstrictive risk for our patients with coronary artery disease or cardiac ischemia. So DDAVP or desmopressin, you can get it as an injection. Now we've got another nasal spray. We talked about one yesterday, but now we have an agent that is produced as a nasal spray, or it can also be oral. So the multiple routes are there because it is specific dosing for specific indications, and we're going to talk about that on an upcoming slide. So key adverse effects, because of its antidiuresis effects, you can get dose-dependent hyponatremia, which can lead to seizures. It drives water retention, so if you overdose, then you're going to have excessive, or if you have excessive free water intake with taking desmopressin, you can get highly dangerous hyponatremia. So be very cautious of that in our kiddos and our elderly population. And that 4,000 to 1 antidiuretic to pressure ratio is a single number explaining why desmopressin's entire clinical niche versus vasopressin's use. So know the difference, the two ADH agents, and what receptors and what action they cause at those different receptors, and why you would choose desmopressin over vasopressin. Okay, so we have the 4 indications on the slide here for desmopressin or DDAVP. So central diabetes insipidus, your desmopressin is going to be your first line agent. So as I mentioned, we have to have caution with patient fluid intake. So make sure if you're treating central diabetes insipidus with desmopressin, we counsel the patients on fluid restrictions and their individualized dosing response. We can also use desmopressin to temporarily treat polyuria or polydipsia for patients who have those conditions following pituitary surgery or potentially a head trauma. So something transient that's causing central diabetes insipidus picture. They're transient, so it can often resolve. So we can use desmopressin temporarily for treatment of the polyuria polydipsia caused by one of those reasons, pituitary surgery or a head trauma. Specialized use has nothing to do with endocrine, is the third bullet there under clinical use. Bleeding control in hemophilia A and von Willebrand disease. We're going to use the IV formula here. We talked about the 3 different ways that it's packaged. And for the hemophilia A and von Willebrand, we're going to use IV. And the DDAVP is going to stimulate the release of stored von Willebrand factor from vascular endothelium, which in turn stabilizes and raises our circulating factor VIII levels. Very different, completely different, nothing to do with endocrine, but you need to be aware of that other specialized use for desmopressin or DDAVP. And then lastly, we can control primary nocturnal enuresis. So bedwetting, we can use the desmopressin to help control. And for the bedwetting, often that's the intranasal or oral packaging or delivery. So now we're going to talk about the opposite problem. We're going to flip over to ADH excess. So that is known as the syndrome of inappropriate antidiuretic hormone secretion. It's a mouthful. So SIADH, syndrome of inappropriate antidiuretic hormone secretion. So as the name implies, impaired water excretion from ADH secretion that continues despite the body having normal or even increased plasma volume, i.e., ADH is being released inappropriately. There's not the normal osmotic or the volume triggers that is suppressing our ADH secretion. So that's in the name, right? So inappropriate releasing ADH because we don't have the negative feedback is not working. So what it's going to cause is hypernatremia, hypoosmolality, because water is being retained disappropriately. We're kicking out antidiuresis with no feedback, shutting it down. So we get dilutional hyponatremia. Urine is going to become very inappropriately concentrated and low volume because we're keeping all those fluids in our system. So the key thing to think about here for treatment when we talk about SIADH is that the hyponatremia is from water excess. This is not sodium based, it's the water, not a sodium deficiency. So that's going to frame your treatment approach from just give sodium, right? Because it's a water problem, water excess, not necessarily a sodium issue where you need to just add sodium. So remember that SAIDH, it's a water problem, not a salt problem. And I will tell you that on the pants, SIADH is very tested. Top tested cause of euvolemic hyponatremia, which is different from hypovolemic, true sodium, or hypervolemic, edematous states hyponatremia. So make sure you commit this one to memory because it's very tested. So the symptom severity in SAIDH is going to track with the rate of sodium drop more than the absolute value. Slowly progressive hyponatremia is going to be better tolerated. Brain has time to adapt versus a rapid drop in the same number. So it's really about the rate of drop. So it's not so much the absolute value. If it slowly drops, even by the same value as a rapid drop, very different in patient symptomatology. Symptoms don't always correlate precisely with the severity or the acuity. So you got to watch clinical suspicion here. Got to trend your patient. So we have to look for underlying causes that can suggest excess antidiuretic hormone or excess ADH. And those include CNS or pulmonary tumors. Classically, you'll hear small cell lung cancer or other paraneoplastic sources that produce ADH. So we have to look for an underlying cause of why we have excess antidiuretic hormone. You'll hear the small cell lung cancer often in a smoking population. We can also get it from a head injury, and there's medications that can cause excess ADH. And we have to consider excess free water intake as a contributing factor. So the biggest thing to establish for our SIADH patients is when did it start? When did we start having issues? To know if this is rapid, acute issue, or if it's slowly happening and our brain and our body's responding over time. That tells us how aggressively or how quickly we're going to correct the deficiency. And as I said, clinic pearl for you that the small cell lung cancer is a classic cause of SAIDH. So always, and we always on our patient history asked about smoking history anyway. But if we're thinking SAIDH, pay special attention to it. And the big questions we have to ask clinically is how long have you been having issues? One of the single most clinically important questions you're going to ask when we're dealing with a patient who has hyponatremia, so that we can determine how aggressive we can be with our treatment. And make sure you think about the causes. The malignancy can cause SIADH, and we told you the most common was that small cell lung cancer, but also mentioned other causes, CNS pathologies, including trauma, infection, stroke, also pulmonary diseases or pulmonary infections, and lots of drugs, right? Lots of drugs can lead to SIADH, including the SSRIs, and then there's some cancer agents. Four factors are we're going to look at to determine the treatment and the rate of that we want to correct the disorder, right? We need to look at the degree of hyponatremia. How low is that sodium? Is the patient symptomatic? Are they severe, i.e., are they having seizures, comas? If they're having seizures, comas, severe symptoms, then obviously that's going to demand urgent correction. So we always need to know whether this process is acute, and you need to know that for SIDH or the sodium issues, acute defined by less than 48 hours, we've been having a problem. And or is it chronic? Is it a chronic issue? And then we need to look at some lab values, right? The urine osmolality and then the creatinine clearance for the kidneys. One second, I have something popping up on my screen for my password I have to correct. Okay. So we have to look at that urine osmolality and the creatinine clearance, help confirm the diagnosis, and then see how well the kidneys are working for concentration ability. So always use these four factors in your decision framework when you're treating a patient with SIDH. So the degree of hyponatremia, are they symptomatic? How long has it been going on? And then how are the kidneys working and what is the urine osmolality? And you'll see that cutoff on the pants, that 48 hours cutoff, less than 48 being acute for SIDH, or greater than 48, we have some response or changes that are taking place over a longer time period, so the body has been adapting. So in emergency settings for SIDH, severe symptomatic hyponatremia, they're having seizures, stupor, coma, respiratory arrest, right? Life-threatening symptomatology. We are treated aggressive, regardless of the actual sodium number. So the symptoms are what's going to drive the urgency for SIDH. If the patient has moderate to severe hyponatremia and it's been under 48 hours, so it's acute, we're going to aggressively correct the underlying issue. And the reason being the brain hasn't really had time to adapt osmotolically to the sodium and the volume. So the brain has less of a risk of cerebral edema with treatment. So less of a risk there. So we have to correct rapidly because it's acute and they're having moderate to severe symptoms. But we have to weigh that against the opposing danger, which is central pontine myelolysis. They're on the first bullet under treatment in emergency setting, right? So if we go too fast, CPM can cause life-threatening hyponatremia itself, devastating hyponatremia. So it's a balance, right? Do we go too slow and we risk cerebral edema risk or brain risk, or if we go too fast, we can actually cause the CPM, which is osmotic demyelinization. That's what central pontine myelinolysis causes, demyelinization. So rapid correction, the concern is always with osmotic demyelinization or that CPM. Rapid correction in chronically hyponatremic patients who are malnourished and alcoholic patients are especially high risk for CPM. But if we have severe symptoms, i.e., seizure, coma, respiratory arrest, those ones I mentioned, emergent treatment, regardless of what that sodium number is, regardless of the sodium value. This is kind of the exception in medicine where we often say we're going to do treatment by going by the number, going by the lab. But if we have those severe signs and symptoms, we're not going by the number, we're treating the symptoms. Understanding the risk of CPM. If we treat this hyponatremia too quickly or aggressively, risking that CPM. So make sure you know the aggressive treatment is warranted by those two bullets there, mainly symptom driven, and the duration of the issue. So treatment in emergency setting, we're trying to correct the hyponatremia at a rate that does not cause those neurological complications. Unlike, like we said, not really treating the number in those emergency settings, we do have some specific criteria about how quickly we're going to raise serum sodium. And those are the bullets there in the middle of the slide, right? Raise the serum sodium by 0.5 to 1 milliequivalents an hour and not more than 10 to 12 milliequivalents in the first 24 hours. Some other sources will say an optimal rate of 8 milliequivalents per liter per day. Maximum of 125 to 130 milliequivalents per liter is your goal for the serum sodium, not getting it all the way up to what we define as our normal range. Have a few options: 3% hypertonic saline, loop diuretics with saline are going to help. And then we also have vasopressin 2 receptor antagonists that we can utilize, and we're talking about those in some upcoming slides. And once again, water restriction. So I have that it is 10 till. We have only a few more slides. Would we like to keep going, or we want to go ahead and take a break? If we want to keep going, just give me a thumbs up and we'll keep driving on. I see thumbs flying all across my screen. We're moving on. And someone typed push. So here we go. So treatment options we went through, and then we're going to talk about the option of the vasopressin 2 receptor antagonist coming up. So now we're not talking emergency, right? We're treating chronic, greater than 48 hours of the hyponatremia. Or we don't know how long it's been going on, and the patient is not severely symptomatic, not having those neurological or respiratory changes that we discussed. So if we're reasonable to assume chronic, if it's mild symptoms and the duration is unknown, it's assumed to be longer duration. So we try to look for the diagnosis in these cases and get to the underlying cause simultaneously while we're making the corrections. So locating the tumor, right? Figuring out which drug caused the SAIDH. Or what is the pulmonary or neurological process that's driving it. So the principal options are there on the slide for you. Fluid restriction, first line, foundational. So if it's chronic, start there. Greater than 48 hours, mild symptoms, restrict the patient's fluids. And then we're going to move into vasopressin 2 receptor antagonists. So different agents working on ADH, and they're known as the vaptans. And we're gonna talk about the specific agents on the next slides. And if the vaptans aren't available in your system, then we can talk about some alternatives for chronic treatment of SAIDH, including the loop diuretics, mannitol. There's some other options. There's some older agents. I think it's actually at the bottom of the slide there, the democyclacine. That's an older option. It's a tetracycline, so an antibiotic derivative that introduces a form of nephrogenic diabetes insipidus. So just be aware of it, that there's other options. But if fluid restriction is enough, our first line after fluid restriction, so second line after fluid restriction is going to be the vaptans, vasopressin 2 receptor antagonists. Always start fluid restriction. If you don't have vaptans in your system, there's a list there just to be aware of at the bottom of the slide. So vasopressin antagonists now. And I remind you on the slide there, we're just going back to normal physiology on the right. It's a repeat from when we started this section. So the vaptans as a class, and we call them the vaptans because that's their suffix, conivaptan and tolvaptan. So vaprazole or Samska, one's IV, one's PO. You see them there in the middle of your slide. These are ADH antagonists. They're non-peptides, so they're synthetic small molecules. They are not secreted by the posterior pituitary. They're synthetic. So we're going to use them clinically in the patients with hyponatremia or acute heart failure, both of which can be associated with elevated vasopressin levels. So the two agents I mentioned, the conivaptan or vaprazole is IV, and here we also have a difference between the affinity of receptors. So the conivaptan has affinity for both V1 alpha and V2. That's why I brought the picture back. So we got both end organ targets are affected by the conivaptan, the IV medication. And the Samska or the tolvaptan is oral, and it's much greater selectivity for V2 over V1. Same kind of situation we saw with the desmopressin versus vasopressin. So both of the vaptans are FDA approved for hypervolemic and euvolemic hyponatremia in hospitalized patients, which include SAIDH specifically. So vaptans do have a contraindication, not indicated if you have hypovolemic hyponatremia. So low volume hyponatremia, we are not giving vaptans. So you got to know that volume status before you reach for vaptan. And just remember the selectivity of the two vasopressin antagonists, the conivaptan being IV and affinity at both the V1 alpha and V2 receptors of vasopressin, and the Samska or the tolvaptan is an oral medication, and its affinity for V2 receptors is greater than V1 vasopressin receptors, much like desmopressin. Okay, so digging a little bit deeper here on the vaptans, the MOA, as I mentioned, high affinity for both V1 alpha and V2 receptors for the conivaptan. But its clinically dominant effect for SAIDH is going to be the V2 antagonism in the collecting ducts, the renal collecting ducts. So it's going to produce aquaresis, so free water is going to be excreted without a lot of electrolyte loss. So key difference between the conivaptan or the vaptans from a diuretic is that free water is going to escape with the vaptans, but there's not going to be a proportional electrolyte loss like you see with some of the diuretics. So how do we use it? We're going to clinically use it to raise serum sodium in hospitalized patients with euvolemic or hypervolemic hyponatremia, because we said a contraindication to the Vaptans would be if you have hypovolemic hyponatremia. You don't reach for the Vaptans then. We also have an off-label use for heart failure if the patient has persistent severe hypervolemic hyponatremia. Safety warning here. We already mentioned it, the osmotic demyelinization syndrome. If you correct too rapidly. So how do we define it? It's on your slide down under warnings, right? That osmotic demyelinization syndrome is if we over rapidly correct the hyponatremia, i.e. greater than 8 milliequivalents per liter in a 24-hour period. I would know that number. I would know that threshold tied to conivaptan-associated osmotic demyelinization risk. And I think if I didn't mention in the earlier slides, I thought I had, it might be on an upcoming slide, but the symptoms of that osmotic demyelinization syndrome, the cluster is going to be dysphagia, quadriparesia, seizures, coma, even death. So yeah, there you have them down, the bullet under warnings on the bottom. That's your symptoms associated with the osmotic demyelinization syndrome. Can be severe and it can result in death. So remember that overcorrection or too rapid of correction using the Vaptans, anything greater than 8 milliequivalents per liter in a 24-hour period, correction of the hyponatremia, you have that risk of the osmotic demyelinization syndrome. Definitely be familiar with it. So now we're moving into the other Vaptan, the tolvaptan, that's the PO medication, or SAMSCA, that we're going to use in the syndrome of inappropriate ADH. Here, higher affinity for V2 than V1, more selective. It antagonizes vasopressin's water retaining effect and increases urine output. So results the same, free water clearance, aquaresis. And we do have a decrease in urine osmolality here and an increase, reflexive increase in serum sodium. How are we going to use it? If clinically significant hypervolemic or euvolemic hyponatremia, and same contraindications. We do not use it if we have hypovolemia with hyponatremia. Specifically, we're going to use it for serum sodium under 125 milliequivalents per liter or less severe hyponatremia that is symptomatic and is resistant to our first line, which is fluid restriction in SADIH. Black box warning here, only initiated in the hospital for the tolvaptan, and you have to do close serum sodium monitoring. Because if you move too quickly, overcorrect too quickly, the hyponatremia too rapidly, here versus the last slide, we're saying greater than 12 milliequivalents per liter for the tolvaptan, you can get the osmotic demyelinization again, same symptoms. In end-state seizures, comas, and possibly death. So make sure you know the tolvaptan has the black box warning. Has to be in the hospital, mandatory monitoring of the sodium. Note that slightly different correction that I gave you from the tolvaptan versus the conivaptan, the less selective. So now our final hormone of the hypothalamus and pituitary axis. Continuing with the second and last posterior pituitary hormone, oxytocin. So it's secreted from the posterior pituitary, not made. Remember, the posterior pituitary does not make hormones. It stores and releases. So it's secreted from the posterior primarily, or the posterior pituitary, primarily during and after pregnancy. So its release is one of those classic examples of neuroendocrine reflexes. So the release of oxytocin is triggered by breastfeeding or even lactating women hearing a baby cry. So a conditioned anticipatory reflex doesn't require physical suckling. So that will cause the let down milk ejection reflex. Don't forget that males, oxytocin is synthesized in the hypothalamus and the testes and the prostate gland. Is produced with ejaculation or is thought to play some type of role in sperm transport and sperm maturation. Many folks don't think about oxytocin in males. So don't forget, it's just oxytocin is not just your labor and lactation hormone. Also produced with ejaculation with sperm and associated with the sperm transport and maturation in our male population. Two major clinical uses of exogenous oxytocin or Pitocin. IV, first for labor induction and augmentation, stimulates uterine contractions. It increases their frequency, force, and the duration of those contractions. So we augment labor with oxytocin. And we don't, usually we're going to do that when the labor is delayed or if it arrests. That we can get some oxytocin on board to help stimulate those contractions of the uterus, increasing force and frequency. The response is dose dependent, which why it has to be carefully titrated with continuous fetal monitoring. Secondarily, we can use oxytocin to control postpartum bleeding. It's going to be given after delivery of the placenta, and that helps to cause a firm, sustained uterine contraction. So that's going to help mechanically compress uterine vasculature and slow down or decrease that uterine bleed, reducing risk of postpartum hemorrhage. Overall, oxytocin considered very safe drug, but do be aware of the adverse effects, and they're there on your slide. Nausea and vomiting, water intoxication, because oxytocin has a mild ADH-like or antidiuretic-like activity at very high doses. So be aware of that. Other side effects, we can see sometimes some seizure activity, confusion, headache, usually from hyponatremia. Heart rate can become a little irregular. There is a rare but serious possibility adverse effect, uterine rupture or postpartum hemorrhage. So basically, this is paradoxically, right? Because the uterine gets overstimulated and exhausted. When do we not use it, even though it's generally safe? Fetal distress or prematurity, no oxytocin. If the fetus has an abnormal presentation, a cephalopelvic disproportion, so, or any other condition that would be predisposing mom to uterine rupture, where forcing stronger contractions of the uterus would be more dangerous, then we hold on oxytocin. The reason that the water intoxication risk exists for oxytocin is because oxytocin and ADH, both those posterior pituitary hormones, are structurally similar. So oxytocin actually has a weak cross reactivity at those V2 receptors in the kidneys. So make sure you're aware of the contraindications for oxytocin and its utilization. Which brings us to the memory jogs, which I'm not going to sit and read to you here. And the end of the lecture, I posted last night that chart that I'd mentioned on the HPA axis, the drugs, they're in there by class in the order of your slide deck. So if you, it's an attachment in the card. So if you go under the block 3 information, you'll see it under the hypothalamus pituitary lectures is the drug reference for the medications taught in that lecture, and it's laid out in the order which we saw them in yesterday and today's lecture. Also added some more check on learning questions from the other lectures that we've completed so far. So we have one lecture, or it's actually 2 lectures, so 4 hours left. It'll probably be like 3.5 hours on diabetes. That's going to be Monday on Zoom or Teams as well from Major Heart. So this will close up what I am teaching for this block, and it'll be finished up by Major Heart on Monday. So I'll be in my office tomorrow and all
The
next week
recording has stopped.
throughout the day. So if you have any specific questions, come by and see me. I will talk to the two class leaders about a possible review over lunch. It'll be optional one day next week. But if we can't make that happen, I will post something on the card for you to review. But your memory jog should anchor your studying anyway. Um, they should kind of show your knowledge, strengths, and weaknesses on what's expected to know for each of the topics during this block. And then the check on learning should help you figure out how to pull out the most important information on clinical vignettes to be able to answer the questions properly. So utilize those two. Don't rely on them. Just like the slides you're seeing here, memory jogs are not all inclusive of everything you are possibly going to be tested on or everything that you need to know moving forward. So, like I said, stop by and see me if you have any questions. I'll post the final check on learnings this afternoon, and I'll be around for questions. And then I'll stop by the classroom to determine if we can set up an optional review next week sometime, because our test isn't until next Friday. I think y'all have 2 large fish to fry before then, right? Test tomorrow and then Monday. So Monday you'll finish up the block, and then we'll move into the final block of Pharm 2, and you'll be well on your way, being ready to move on with your next semester. So like I said, come see me if you need to. I'll be around, and thanks for your time.